Okay, so we'll start with the indications for cardiac CT angiography. Now, Andrew has already covered a lot of what I'm going to say, so I'm going to run fast through those topics that Andrew has covered and just focus on some salient points about them perhaps, and then look at some of the indications that he might not have included in his talk. Okay, so the main guidelines, or you can say appropriateness criteria for different indications for cardiac CT angiography actually are in this document, which came out back in 2010, and I think it's being revised now, but no new edition has come out. So this briefly is like an expert consensus document, mostly from people doing cardiac imaging in America. And this probably gives the most practical indications where most experts agree where cardiac CT angiography is a useful technique or not a useful technique. So that's exclusive to cardiac CT angiography. And then you have three other guidelines. So the British One-Nice guidelines, which we have been talking about from 2010, which are being updated. Then 2013 ESC guidelines and 2013 AHE guidelines. Now they are more specific to stable chest pain. So there are a wide variety of indications that we now use cardiac CT for. Now, one thing to point out is a lot of people use the word coronary CT angiography, and it's a word I think is not appropriate for the technique, because the CT that we do is not just a coronary CT, although that's the main reason why we do it. But it's a cardiac CT, so you're looking not just at the coronary arteries, but you're looking at the cardiac chambers, the myocardium, the valves, etc. So there are a lot of things that we are trying to assess on a cardiac CT angiography. So, both stable and acute chest pain, CT is obviously now becoming increasingly used technique. Then patients with breathlessness or heart failure, patency of stents and grafts, TAVI assessment. So there are a number of indications, and some of these we will talk in more detail in different lectures that we're going to have this week. So I'm just going to go straight to first very briefly touch on asymptomatic individuals for risk assessment. So coronary CTA, is it indicated or not? And as Andrew pointed out, that we don't have evidence whether performing CT angiography in patients who are asymptomatic would result in improved prognosis or not. Now this is data from confirmed study of 7,500 patients who were free of symptoms, free of known coronary artery disease, and what they found that the prevalence of more than 50% disease in their data was about 25% people had that much, and 4% had 3-vessel disease or left main stem disease. So that's similar prevalence to what I have in my data from Harefield in symptomatic patients, not very different. Now, when they looked at the outcome of these asymptomatic people over roughly 2.5 years, what they found that indeed there is increased mortality in those who have obstructive disease compared to those who have non-obstructive disease. But when you model it with different parameters, they found that the combination of risk factor and calcium scoring itself is good enough in terms of prognostication, and the information from CT angiography does not add any further in these patients, because we're retreating these patients to change their prognosis, not to change symptoms, because they are not symptomatic. So that's the one thing that is where I think experts still think that CT angiography is not the right technique to use in largely in asymptomatic people. But there is a possibility that if you do a CT angiography in a person who is asymptomatic and you show plaques, then perhaps they can modify their lifestyle, and their risk factors may be modified, and that could perhaps lead to improved outcome in future. So there is a possibility of that. And the Scott Hart trial that some of you might have heard actually has shown this, but in symptomatic patients. So we'll come to it. So stable chest pain, so a lot of data again in terms of accuracy. Andrew showed this meta-analysis from 64 slice CT scanners. This was published back in 2008, so it's pretty old now, but pretty much people are still relying on this. I think since since 64 slice CT scanner comparison studies with invasive angiogram, no further comparative studies have been performed, because the spatial resolution of the CT has not improved any further. The temporal resolution have improved because the scanners are becoming faster, radiation doses have improved, artifacts have become less because you can scan now much faster, so the artifacts are much less. So that's where probably accuracy have improved between, say, a 320 slice scanner and 64 slice scanner, but the actual spatial resolution has not much improved. So that's something to bear in mind. So again, just to emphasize that CT angiography has very high sensitivity. Specificity is around between 80 to 90%. Now this is quoting a the positive predictive value of about 93%, but in practice, in real life, it is somewhere between 60 to 70, 75%. It would depend upon lesion to lesion how accurate your assessment of the significant stenosis when you compare with invasive angiogram will be. So in some patients you will say it's moderate and it will be just mild stenosis on invasive angiogram. Depends upon how well you can see the lumen, how well you can see the stenosis. But the most important thing with CT angiography is the very high negative predictive value. So it's almost 99–100% in a good quality study. And again, when we compare with stress imaging techniques, you can see that a normal CT angiogram literally almost excludes coronary artery disease, while a negative stress imaging technique, you will still have plaques in between 10 to 20% of patients. This is more than 50% plaques. You will have many more plaques which are non-obstructive, but even obstructive plaques you will have. And something that we cannot miss on CT angiography is left main stem disease and 3-vessel disease. You will always identify that on CT angiogram. Now, 3 multi-center studies comparing 64 slice CT angiography with invasive angiograms are worth looking at, and these are the accuracy study, then core 64 study, and the last one is from Netherlands. And these 3 studies again point out to a very high negative predictive value of CT angiography. So some key studies I'm pointing out which are worth reading, going through, and understanding how these data have come about. Now, Bayesian approach is how we have traditionally been using in terms of our diagnostic workup of patients coming with stable chest pain. So we assess a pretest probability based on the symptoms and risk factors, and Andrew has gone and based on what pretest probability we think for a particular patient, we do different testing. So again, just to emphasize that the pretest probability that we calculate from Diamond Forrester and the Duke's scoring is very high. So the data was from 70s and 1980s, the data that they had based their methods on. This study is very good. This is published in 2011, multi-center European and American data. And this was calculating pretest probability on invasive angiogram, but on current cohort of risk, you can say, and the prevalence of significant CAD in their cohort was 50%. So they also felt that there is overestimation of the Diamond Forrester and Duke's criteria by about 20–30%, even based on invasive angiogram. But the confirmed study that is basically purely based on CT angiography, that show that almost the prevalence of coronary artery disease is about 10% of more than 70%, and more than 15% is 18%. While if you did Duke's assessment, that will be about 50%. So there is significant overestimation of pretest probability by the conventional Duke's and Diamond Forrester method. So something we have to bear in mind. It's very important to understand this fact. So, and hence probably quite wisely, the new NICE guidelines are ditching completely the pretest assessment now because of so much variability. So I will skip all this. You have heard this number of times. This is the ESC guidelines, which suggest that coronary CTA and functional stress imaging is good in patients with low to intermediate pretest probability. And now, so it is patients with, so which patients is CT angiography best for? So this small study by Mittal from Netherlands again show that if you have low to intermediate risk people, there the specificity of CT angiography and negative predictive value is highest, while if you take patients with high risk, high pretest probability, then the negative predictive value is lower. So you will going to have patients in the high pretest probability where you are bound to suggest further assessment with invasive angiogram or stress imaging. So the usefulness of CT angiography in higher pretest probability patients is lower comparatively. But there are instances where CT angiography is still useful. For example, where you want to evaluate left brainstem disease, which you can't miss on CT angiography, and disease in LAD, for example, proximal and mid segments of LAD, or proximal mid segments of any of the arteries, circumflex artery or right coronary artery. You will not miss the disease there. So prognostic data with cardiac CTA. So again, number of studies, some of which Andrew has shown you already. So more the degree of stenosis, more the number of vessels involved, the worse is the prognosis. This is the data from Harefield registry, again showing the same information. So PROMISE trial that was randomizing patients with stable angina into functional testing versus CT angiography, they failed to show any difference in outcome, as Andrew has shown. So means that you could do either test in terms of outcome. There's no difference, but we have to be mindful that the follow-up was only for 2 years or so. So 24-month follow-up. So it's a short-term follow-up. And I think the prognosis from non-obstructive plaques has not come out in this follow-up. And if you follow up for 5 years, 6 years, you probably will see there's divergence of the curves with more events in the patients with worse CT, with disease on the CT angiography. Now, SCOT heart study was conducted multi-center in Scotland, and they randomized about 4,000 patients in CT angiography versus standard care. And most of the patients with standard care received a stress exercise test, I think, just exercise test. And their follow-up was short. Now, what they found was the endpoint was that how good is CTA compared to standard care in diagnosing angina at end of 6 weeks. That was the endpoint, primary endpoint. Secondary endpoint, they looked at all-cause mortality and MI and unstable angina. And what they found that if you use CT angiography compared to standard care, there was reduced event rate by about one-third, about 37%. That's what found. And in another study published this year in JACC, they demonstrated that this reduction in the event rate by one-third based on CT angiography was primarily driven by the change in lifestyle and change in preventative therapy. So patients who had plaques on CTA were given statins more aggressively, antihypertensives, etc., compared to the other patients. So now coming to acute chest pain. Now three studies are most important here. So there have been multiple randomized trials, mainly in US, comparing CT angiography with standard care. And standard care in US is nuclear scintigraphy, in patients coming to the emergency department. And these are patients who have normal ECG and have negative troponin. So they are lower risk, much lower risk spectrum of patients coming here. And all these three trials have shown that the time to discharge or the length of stay in the hospital is reduced by about half compared to the standard care in US. Some studies are showing that cost is less, some are showing that cost is similar. So that again depends upon what cost you input into the modeling process. And none of the studies found any difference in outcome. So outcome-wise, any of the approach is equally good. In UK, we are currently conducting a multi-center study called Rapid CTA. Anybody has heard of this? This is being conducted in 36 sites in UK, and they are including patients who have acute chest pain, which is not a STEMI, but there is abnormal ECG with ST depression more than 0.5 millimeter, or history of previous ischemic heart disease. So they're including patients with previous PCI or previous grafts and troponin rise. So basically they're taking any patient who has an end STEMI, right? So only patients they're excluding are patients with STEMI and heart failure. So this is ongoing now, and we wait for results probably by next year or the year after, when they complete 2 years of follow-up in these patients. So they, I think, plan to randomize around 2,000 patients to the CTA group and 2,000 to standard care group. Okay, now in the acute setup, we also have the high sensitivity troponins. So how can one use high sensitivity troponins in conjunction with CT angiogram? So there is this paper which I have quoted here, which is quite an interesting one, and they have tried to combine the use of CT angiography in low risk patients with a high sensitivity troponin. And this is interesting. It's quite a busy slide. I don't want to go in this just to avoid this point of view of time. So then for acute chest pain, again, the other concept is where you're not sure that you're looking at patient with coronary artery ischemia or looking at PE or acute dissection. So what we call triple rule out procedures. We actually do more and more of these procedures, unfortunately or fortunately. CT has been done for several years to rule out these three conditions, but it is very challenging, and it's challenging because to ossify both the coronary arteries and the thoracic aorta and the pulmonary arteries in one go can be quite difficult in patients. So there are protocols, contrast protocols, where you can achieve in majority of the patients, but not in all patients. And it's better clinically if we can say, okay, you want to exclude just PE, where the protocol is different, compared to excluding coronary artery disease and aortic dissection, for which there is one separate protocol. But it can be done. But there is no randomized trial or study looking at the use of CT angiography in this cohort. But in practice, I think most centers who do ECG gated study would do triple rule out studies in some way or the other. So patient with coronary artery stents. So you would use CT if the patient has atypical symptoms. If patient is having typical symptoms, probably go for a cath. Stents more than 3 millimeter or more are ideal to exclude any in-stent stenosis or thrombosis, and ideally those with 3 millimeter stents, you're talking about mid or proximal part of coronary arteries, and particularly for left main stem stents, CT angiography is no-brainer. It's very easy to exclude any problems in left main stem stents. Now bypass surgery. So CT angiography nicely shows the number of grafts patient has, their location, patency of the grafts is very good for, and it can show the proximal anastomosis of these grafts, like in this image. It very nicely shows the distal anastomosis of grafts, like here. No problems at all, and there are a number of studies looking at the accuracy of CT angiography versus invasive angiography in excluding occlusion of the grafts. And CT is good for that. Where CT is not good is evaluating the native coronary arteries in graft patients, because they have heavy calcification. So once they've had grafts, then over a period of months and years, there is an accelerated atheroma formation because the blood is bypassed from these arteries. Hence, evaluation of native coronary arteries becomes difficult. So normally, patients we receive with bypass grafts for CT angiography are those who have had an invasive angiogram already, and the cardiologist has not been able to identify one or more grafts. So that's one main indication. And second indication would be that patient does have grafts in there. You want to avoid invasive procedure. First, you do CT angiography if the symptoms are atypical. So that's one approach to use CT angiography. Patients with heart failure, again, Andrew has pointed out that new onset heart failure, if the patient is young, and how you define young is, I would say, men less than 60 years of age and women less than 70 years of age, where you can more convincingly exclude significant artery disease. CT angiography is a good technique to use as first line. Now, second indication in patients with heart failure would be to evaluate ventricular function when you want more precise estimation. Perhaps echo windows are not good, or you could not do MRI scan in these patients because they have a pacemaker or etc. There's contraindication for MRI scan. And similarly, we can use CT for myocardial viability for similar reasons as we would do ventricular functions in patients with ischemic cardiomyopathy. And I have a lecture tomorrow on this topic. Okay. So in valve disease, we can use CT angiography to estimate degree of valve stenosis, particularly for aortic valve, where the findings on echo are not clear cut. And we now routinely use CT angiography to assess the aortic size of the aortic root and aortic annulus, and also to look for peripheral access for patients being assessed for TAVI procedures. In patients with arrhythmias, CT has been shown to be useful in mapping out the anatomy of the pulmonary veins draining into the left atrium. I must say, in my hospital, we are not using it for this purpose very much because the navigation systems used in the EP labs are not quite good. So they can superimpose the anatomy of pulmonary veins quite nicely on your angiographic images directly in the cath lab. So we rarely use CT for this purpose now, but this is one of the indications it can be used for. Then mapping of the coronary sinus and lateral marginal veins, where there's difficulty in inserting the coronary sinus lead for CRT device. CT can be useful, particularly in patients where the first time insertion is difficult. Sometimes the anatomy can be different, or veins may have stenosis or unusual valves, etc. So CT can be very good for that purpose. And the third thing is here for assessment of thrombus in the left atrial appendage. So we know that TOE is the gold standard for that purpose, but CT done rightly is also a very excellent non-invasive technique to exclude left atrial appendage thrombus. So in patients who have already had a cath, we would often receive requests to exclude anomalous coronary arteries. So because either they could not be cannulated on the catheter angiogram, or they could be cannulated and they could be seen, but to assess their course in relation to the aorta and pulmonary artery, CT angiography is being requested. So CT is very good for that purpose. Suspected left brainstem disease, when the significance of that is uncertain, and for stent planning, for example, in patients with chronic total occlusions. And other indication in this category would be where arteries are occluded on the invasive angiogram or have tight stenosis, and the surgeons or the interventional cardiologist is not able to see the distal targets, distal vessel very well. So distal vessel, whether is it patent or not. So we do CT angiography with slight delay in these patients to see if the lumen of distal artery for purpose of grafting or for purpose of revascularization is patent and disease-free or not. So that's another indication. So coronary anomaly, Minnie is going to speak to us next after this. So CT angiography is a gold standard technique for this purpose. Then other situations we use CT angiography would be for patients who are undergoing preoperative non-coronary cardiac surgery or aortic surgery. So again, I would use CT angiography in these patients who are younger, so less than 60 years, or less than 70 years women. Again, just to exclude obstructive coronary artery disease, CT angiography can be performed. Again, no proper studies done in this cohort of patients, but we think intuitively if the degree of stenosis is less than 50%, probably is fine. Then we are routinely using CT angiography for patients with heart transplant. So in Harefield, we have a large cohort of heart transplant patients. And they have a routine, they used to have routine invasive angiography after every 1 or 2 years, they will have it during a lifetime. So now we have replaced invasive angiogram with CT angiograms in this patient cohort. So once we know on CT angiogram that they have 50% or more disease, then we recommend that they have further follow-up with invasive angiogram. But till that time, we are following them up using CT angiography. Okay, then we have the traditional indications for CT angiography. Patients with suspected cardiac masses, pericardial thickened pericardium, want to exclude calcium in the pericardium, constriction, etc. For looking at dilatation of the aortic root of the thoracic aorta. For dissection, for acute type A dissection, CT angiography is probably the best technique if you want to exclude that in an acute patient. Okay, so thank you. So that's a very brief overrun of the indications of cardiac CT.